I've been coming to these meetings since 1987, so I've been seeing the organization grow and prosper and pay attention to different things that came along to help people rehabilitate from musculoskeletal injuries. So it's exciting to see all these new things, and yet, all the people that you're going to hear from sort of have a philosophy that, you got to start somewhere, and the proper place to start is not with PRP and stem cells. It's to start with an understanding, a cognition, if you will, of how an injury happens. How do you fix an injury? How do you look at an injury? How do you evaluate? How do you go after an injury? So that's sort of what we're going to talk about this morning. And prolotherapy is sort of looked at by many as sort of an older type of treatment, and who needs that? If you've got PRP, it's so much more snazzy and sexy and everything. So those are the kinds of things we're going to talk about this morning. There we go. So who here does prolotherapy now? Okay, great. And who does PRP? And who does stem cells? Okay, so everybody's getting their fingers in lots of stuff. And when people do PRP now, who does it with prolotherapy, and who does it with prolotherapy, and who does them together? Okay, so there's a lot of folks that have sort of understanding of how they might mix together. Well, let's. I've been at this a long time. Let's leave it at that. And how many people have never done prolotherapy? So we got some newbies in the audience. Great, nice to have you here. The objectives of this lecture is basically why you need to know prolotherapy to do regenerative injection techniques. We're going to sort of define it and package it a little bit so you have an understanding that's got some basis, and talk a little bit about the studies in the literature, indications, usage, and injection techniques. So why prolotherapy? Well, first of all, prolotherapy is also a regenerative injection technique. In its most basic form, it's a form of immune upregulation. It's a way of stimulating the immune system to do something you want it to do. The Prolo is a concept also of understanding musculoskeletal tissue injury and how to repair it. It's also a methodology, how you do it. We would also call prolotherapy. How you would approach a shoulder in terms of treatment, whether you are looking just at that MRI that says there's a tear in the rotator cuff supraspinatus, and you go after that with some PRP, versus looking at that whole shoulder and treating it as a prolotherapist would. So it's a methodology of treatment as well as a form of treatment. And we have more and more randomized controlled treatments studies being published. This stuff really works. A couple lessons from history. George Hackett sort of was the guy who brought prolotherapy to the marketplace. He's a general surgeon out of Ohio, and he began to think about the nature of injury and decided it was, in fact, mainly ligamentous. He actually did diagnostic blocking certain ligament structures and finding out, like a modern interventional pain person, that if you block the pain and it takes away the pain with anesthetic, then you have found the source of the pain. Fortunately, he was looking at the ligament structures and finding out that the ligaments were actually the cause of pain. He then worked in his own laboratory, and others were doing this as well, but we'll just focus on George for a moment. Found out how to fix ligaments by injecting them, and worked with mice and rabbits and rats and whatever, and found out he can actually heal ligaments. So he comes up with this great theory about where pain comes from, that ligaments are the primary source of musculoskeletal pain, and he finds out how to fix it. How cool is that, right? So about the same time, and he finds out, you can use a sugar-based substance, which is pretty safe to use, and everybody can apply it. So he finds a treatment that's not difficult to do, that everybody can be taught to do it. So we're all home free now, right? We got a cure for musculoskeletal pain. About the same time, Mixter and Barr figured out that the lumbar disc could be operated on, and it sort of threw us into a tailspin in terms of musculoskeletal pain. We lost that momentum that George Hackett was trying to achieve, and we became a sort of surgical solutions medical practice society. And we started to look at the disc as the cure for everything. People got disc surgeries left and right. And what do you know? They didn't always work. You know, they worked great if the disc was in fact the problem, but unfortunately with a lot of new toys, you start using one thing for everything. So we basically entered an age of spinal dark ages, you know, where we didn't make any further progress in terms of musculoskeletal pain, and we became very surgically oriented. And that really translates into this very day. In 1982, Prolotherapy was rediscovered by this organization, the AAOM, and it was formed to teach it and to make sure that people understood how to do it and to train them how to do it. And it is basically, that's our goal, and that's our platform why we exist. So we wind up teaching prolotherapy, but over the years that's of course grown into regenerative injection technique. We recognize there's lots of ways to treat musculoskeletal pain that are non-surgical and that are regenerative in nature. Prolotherapy is one of them, and the concepts of prolotherapy apply to all of them. So that's really what we're going to talk about this morning. The definition of prolotherapy means to proliferate, right? It's an injection of a substance to stimulate the growth of connective tissue, and by connective tissue growing, it makes a structure stronger. And we can take painful and weakened ligaments and make them stronger. The pain goes away. So prolotherapy is also known over the years as sclerotherapy, ligament reconstructive therapy. I think we've had lots of names. Let's talk about how it works. There's 3 phases to healing. You know, there's an inflammatory phase, a tissue regeneration phase, and there's a tissue remodeling phase. They all take a different length of time. The inflammatory phase, you have injury to the cells, and you know, this is the actual thing where you sprain your ankle and you pull that ligament and there's some bleeding, and the contents of the cells are spilled open. Debris and chemicals are into the intracellular matrix, extracellular matrix. They attract other cells to the area. That's the inflammatory reaction. Now, we like this inflammatory reaction because it leads to what? It leads to healing, right? So this is how your body naturally heals itself. First it has to inflame, then it starts to repair. This lasts 1 to 3 days. The proliferative phase is a phase in which other cells start to come into the area and grow and create more copies of themselves. So you have fibroblasts creating more fibroblasts, and stem cells creating fibroblasts, and fibroblasts creating cartilage, collagen material in the extracellular matrix, and that's what's doing the healing. There's new blood vessels stimulating, and this only happens with a fresh injury. Why does prolotherapy work? Because we create a fresh injury. We create this whole concept. We create the whole healing cascade again. So this lasts 10 days to 2 weeks, and then the remodeling phase. So you have all these collagen fibrils that are formed, but what makes them strong? What makes them functional? Well, over time, they start to squeeze. I don't know if you remember your biochemistry and your basic stuff, but the collagen fibrils start to turn, and they get cross-linked by the sulfur bonds, and that squeezes out the water molecules, and that collagen fibril becomes thicker, denser, and shortens, doesn't it? That shortening and that thickening, that's what creates our strength in the structure. So if we create some sort of artificial healing, it's not artificial, it's real healing, but we stimulate it to start at a spot that's been weakened, we can actually create strength in that spot, and we can rebuild that spot so it's better than new. So this occurs over 2 to 3 months and actually continues to occur over a period of a year, although the curve flattens out on top. And this is the crux of why things get strong, is that remodeling. Your body Remember, it tends to put down tissue where it needs it, and it takes up tissue where it doesn't. It applies to bone, it applies to ligament, tendon tissue. It's only going to get as thick as it needs to be. It's never going to overgrow, and it needs stress of being used to actually grow to that thickness or that strength level. So, jumpstart the healing process. Obviously, we don't want to use anti-inflammatories, and most of us get that. So, the history of prolotherapy, well, you know, it has a history. We like to say, oh, well, way back a long time ago, people were using stuff, and we'll call that prolotherapy. Was it prolotherapy? I don't know. They used hot irons to heal people and things like that. But really, it began in this century, in the 1930s. And people like George Hackett and others started experimenting with injury and with healing injury, and they came up with the concept that ligaments are important and that you can heal ligaments. So prolotherapy is also, though, it's a thought process. It's not just, you know, putting a chemical on a structure and making it get healed. It's also a thought process, how you think about that healing. For instance, you know, I'm also, in addition to being a regenerative medicine physician, I'm also an interventional pain physician. I can tell you my associates look at the SI joint as a singular structure that you inject into the joint intra-articularly. How many interventional pain guys in the group here? Tell me if I'm telling any lies out of school. So you inject the joint intra-articularly, and if it makes the pain go away, then you've diagnosed that as a sacroiliac injury, okay? And treatment just involves either more injection of cortisone into the joint itself, or if that doesn't do it, you can block the nerves going to the joint, and then you can radiofrequency them, the lateral branches. So those of us who understand the SI joint from a prolotherapy concept, who understand ligaments, would tell you that the SI joint pain comes mainly from its ligament structures, not the joint itself. It's like injecting somebody with a rotator cuff tear and injecting the glenohumeral joint. It's not going to fix a rotator cuff tear, is it? Well, injecting the sacroiliac joint isn't going to fix a sacroiliac joint problem if the problem is in the ligaments and the weakening of those ligaments and the instability of that joint. So what do you have to treat? You have to treat the rest of the structures. And that's the prolotherapy concept that we're talking about. That's what has to happen, is you have to start thinking more globally. What made that area hurt? What are the other structures involved? Maybe it's the joint above. Maybe it's the joint below that has to be stabilized. You have to understand biomechanics. You have to understand tensegrity, how one structure depends on another structure. The gluteus medius, the greater trochanteric bursitis, another common area where, you know, regular docs inject that spot with cortisone all day long. But why does somebody get greater trochanteric tendonitis or bursitis? First of all, bursitis doesn't exist. You know, those of you who use ultrasound, have you ever found a bursitis? Absolutely not. It's a tendinopathy, and it's usually the gluteus medius tendon that hurts people. So why does it hurt? Well, it so happens the gluteus medius tendon gets overused when the sacroiliac joint is unstable. So the next time you run across a greater trochanteric pain, look to the sacroiliac joint. I'll bet you'll find it out of position and unstable. That's the prolotherapy concept of looking beyond where the pain is to the structures that might be causing that pain. And what do all these things have in common? Well, they're all ligament failures, right? The sacroiliac joint, the greater trochanteric, it's all ligament failures. If you enhance the ligament structures, you're going to enhance the joint. So we have to rethink ligaments. We all got taught the structures in medical school and basically, you know, where they attach, but we never got taught what they do and why they're important. We understand it for an ankle sprain, right? Okay, we understand some of the, you know, the talofibular ligament got sprained. Well, what about the spinal structures? They all have ligaments too, but we totally ignore those when it comes to treating pain of the spine. There's only basically 5 things that can hurt, right? Muscles, ligaments, joints, nerves, and discs. Well, it's pretty easy to understand the muscles and the joints and the nerves and the discs, but nobody really has a great understanding of ligaments. And once you start to understand what ligaments can cause and what they control and how to fix them, you've opened up a whole opportunity for yourselves to be able to treat injuries much more effectively than you've been treating them. So here's an example. There's a 36-year-old female with right cervical pain radiating down the medial aspect of the scapula. Non-radicular, normal range of motion, normal sensation, normal strength, positive trigger points in the trapezius, the levator scapula. I was just talking about a case exactly like this with one of you yesterday. Positive trigger points, levator scapula, rhomboids, scalenes, cervical paraspinals, tender in the cervical paraspinals as well. Possible diagnoses, myofascial pain, right? Facet syndrome if you're an interventionalist, though, because you know that referral structure, that referral pattern is also coming from the facet joints. Well, look at this referral. These are from ligaments in the neck. And look where it refers to, exactly where this person was hurting. And that's ligaments creating this referral zone. We call that a sclerotome, right? So if you don't know that ligaments can create pain, and you don't know where they create pain, you're sort of lost, because trigger points are just a symptom of underlying structural instability. So once you figure this out and you can fix the underlying structural instability by fixing the ligament structures, all the trigger points melt away. So those of you chasing trigger points, you're chasing symptoms, you're not chasing the cause. 42-year-old young man with back pain, right L5 radicular symptoms, negative weakness, negative sensory, negative reflex changes, straight leg raising positive for posterior thigh pain, fairly large bulge at L4-5, brings in an MRI. Look, doc, I got a bulge. Presumed diagnosis, right L5 radiculopathy. Any other possibilities? What do you think? Who thinks there could be other things going on? Yeah, we got some smart cookies in the audience. Look at these ligaments. Here's the sacroiliac ligaments. Creates pain in the L5 distribution. More of them. The one on the left. This is the iliolumbar ligament. Creates groin pain, creates testicular pain. People get orchiectomies for this pain because the doctors don't know about the iliolumbar ligament. It's nuts. Look at the ones on the right. Sacrotuberous, sacrospinous, exactly in the distribution of the S1 nerve. And these go all the way into the foot, right? So if you don't know about these ligaments, you're missing the whole boat. So that's what we're here to teach. That's what the AAOM is concerned about, is how we understand ligaments, that we know how to treat them. Yes, prolotherapy is a great treatment, so is PRP, so is stem cells. They all have their place. But unless you understand ligaments and you understand why they're so important to us and why they're so important in chasing musculoskeletal pain, your treatments will be not as effective as they could be. You're going to miss a lot of diagnoses. You're going to miss a lot of treatment opportunities. How about the neck? People come in with headaches. Take a close look at this diagram. This was created by George Hackett going on 100 years ago, 85 years ago, all right? So look at the distribution of his pain into the temple area, the frontal area, the occipital area, all coming from the nuchal line. Well, once you understand this and you understand you can throw some dextrose injections on that nuchal line, boy, how many headaches can you fix? Tons. But if you don't know this, you're going to be chasing greater occipital nerves with very limited success, usually failure, and you're going to be tracing facets with cortisone or whatever, and you're going to be chasing trigger points. But once you know that the neck is a mass of ligaments, all of which create pain, you can go after these ligaments and you can really help people. So the implications to your treatments, to adding ligaments to your thought processes, the myofascial trigger points and spasm become a symptom of ligament failure, and joint instability, not a diagnosis of themselves. A painful joint becomes a joint, yes, but it's also the ligaments around that joint. And you understand that you're only going to make that joint feel better if you increase the integrity of the joint, the strength of the joint, and you make it a stronger, more effective structure. And you might have to treat the joint above or treat the joint below, which is unstable, and transferring its forces to that joint. So you have to rethink how you're thinking things. Radicular pain, don't believe it just off the bat. Think about other things that can cause radicular pain, because ligaments can do that. And if you don't know about that and you don't poke at them, you're going to be misdiagnosing people of having radicular problems that actually have ligament problems. Big difference in treatment. So Prolo is a methodology. It teaches us how to treat the entire structure, not just what's on the MRI or the structure you've seen on the ultrasound. And that makes cure more likely, okay? For example, if you're going to treat a whiplash injury, you have to treat the C2 through C7 facet capsules. You have to treat the supraspinous and intraspinous ligaments, the right and the left nuchal line, at a minimum. And that's going to fix your whiplash injuries. If you go after it piecemeal and chasing trigger points and whatever, and it's just not going to be nearly as effective. So treating an SI joint problem, if you understand all the ligaments and how they work together and make the lower back strong, you're going to understand that you need to treat not just the sacroiliac ligaments, the deep and the superficial, the iliolumbar ligaments, the sacrotuberous and sacrospinous ligaments. You're also going to treat the 4-5 and 5-1 facet capsules at a minimum. You might go a lot higher than that. You might go a lot more in the ilium and the glutes and the trochanter, depending on that person. But this is at the very minimum how you would treat a sacroiliac problem if you understand ligaments. So that's the importance, because you're only going to get a treatment success if you understand the whole ball of wax. Prolotherapy has an 80% success rate, tends toward curative. So in other words, it's 80% of the people you will do it on will get basically cured from their problem. You will fix them. 20% will have difficulties getting better. Don't ask me why. The advantages of prolotherapy, very simple to perform once learned. It's not easy to learn. It's technical. But there isn't anybody in this room that couldn't learn it. There's no equipment or preparation. It treats larger areas, for instance, the cervical spine, the lumbar spine, thoracic spine. Pretty hard to treat those with other forms of regenerative treatment. You can't get enough PRP unless you're doing it by hand to treat a thoracic spine. As a method of treatment, it addresses the entire organ, ensuring more long-term success. More affordable for many injuries. Obviously, dextrose is pretty cheap. Same outcomes as PRP. I've been doing both for 20 years, and same outcomes. The PRP does it in half as many sessions, but the prolotherapy gets there just the same. Exception if you have a tear. PRP might work a little better, a torn ligament or a torn tendon. 5% of people respond to prolotherapy, but not PRP. So PRP has its failures also, and when you have those failures, think about trying prolotherapy. Basic proliferant solution, 12.5 to 25% dextrose, diluted with an anesthetic. Historical basis, there's lots of stuff that's been tried. We don't use any of those anymore. Research basis, I'm not going to spend a lot of time on, but it's in your packet. There's some very good studies, beginning with George Hackett, who did something like 1,600 cases, showing 80% resolution. Connective tissue research, clinical studies. There's a lot of stuff that's been done beginning back in the 80s with double-blind studies. Coming up to the recent, Dumas in 2012 did a really nice study, a randomized controlled with crossover. Topal, Gaston here. Gaston overslept. Gaston Topal from Argentina did this study along with Dean Reeves, and for Osgood-Schlatter disease, really proved it beyond a shadow of a doubt. This is the standard of care now for Osgood-Schlatters. Robigo and Patterson did a nice study in 2013. Again, randomized controlled study. Basically, there's over 5 level 1 studies out now on prolotherapy, 10 or more level 2 studies. So what's my point? Prolotherapy is no longer experimental. okay? You don't have to tell your patients this is an experimental treatment. It's proven to work, okay? It meets the U.S. Preventative Services Task Force recommendations when doctors should tell their patients about a treatment. So, indications, patient selection. Ligamentous insufficiency or laxity, chronic sprain, strain, unresolved myofascial syndrome. It's a diagnosis of exclusion, really, since it's difficult to, once you develop experience, you can sort of smell a ligament structure problem as you see the patient. But in the beginning, you want to rule out common things like radiculopathy or fracture and other things that can cause pain. And you might want to try other treatments before you resort to prolotherapy, particularly if you're new at this. There's no rule against starting with prolotherapy, but we all have to think medical legally in this country, and the reality is that people want to know why plain physical therapy wasn't tried first before you stuck a needle in someone and paralyzed them. Okay? So anytime you put a needle in someone, you're crossing a threshold, and you have an obligation to that patient that you have tried more conservative measures that may have worked. And the public will hold you responsible for trying those conservative measures first. Okay? So bear that in mind when you jump into prolotherapy with all your gusto and excitement that you're going to leave this conference with. So clinical characteristics is, I use positive diagnostic blocks a lot. In other words, when somebody comes in with neck pain and I think, I bet it's coming from these facets and ligaments in your neck, I'll actually put a diagnostic block in there with anesthetic, and they'll say, oh my God, my pain's gone. And I'll say, well, we have a couple options for treating you. One, I can put some cortisone in there, and two, we could do some regenerative treatment. We can rebuild the ligaments that have been injured in your accident or have been injured through age, and we can rebuild those ligaments. And most people will say, well, shoot, I want to get stronger and get fixed. I don't want just cortisone covering up the pain. So, but give the patient the option of doing that. You have to present all options to patients. If you just lead them down a narrow tunnel of regenerative techniques, you may be wondering why you did that one day when they're not happy with the outcome. So, and let them make the decision. Don't force anybody into a decision. Present them with the facts, present them with your diagnosis, present them with your diagnostic block results, and say, this is what I think's going on, and this is what I think will help you. Here are the other treatments available to help you. Let the patient always make the decision. So, let's see, we talked about that. I usually treat in 4 to 6 session blocks. A shoulder might take 4 sessions. A lumbar spine will take about 6 sessions in my hands. An ankle about 4 sessions. So 4 to 6 sessions is generally the rule for how many treatments it takes to take care of prolotherapy, to take care of a problem with prolotherapy. And then I sort of wait a couple of months and see how things heal. Some people take more than that. Some people take less. There's a bell-shaped curve, and most people are under the bell, but some people are on either end, taking a little more, a little less. If they're better than 30%, then I consider that it's working, and I would do more. If it's 90% or more, if it's 100%, I'll stop. But if it's 90%, I'll continue. The question is when not to continue. If it's 30% or less, that's pretty much placebo in my head. So I look for something else. I'll probably turn to PRP at that point or some other treatment that might enter my mind. Become technically proficient. The AOM's organizational context is teaching this stuff. We're very good at it, and we have a staged program where, level by level, you get better and better and better and more confident about what you're doing. This is a treatment that depends on you knowing your anatomy. You really have to know it, and when you think you know it, you figure out you don't know it so well, and you start studying it some more. Always obtain an informed consent. Use routine sterile prep for putting a needle in the body, the same prep you would do for injecting a joint. Discontinue nonsteroidals when you're doing this. The technique, you advance to where you advance the needle until you hit the point where the ligament attaches to the bone, okay? That's your sweet spot because that's where you want to strengthen the emphasis. We don't do this mid-shaft in a ligament or mid-body. We do this at the attachment sites. That's where all the action is. That's what creates the strength in the entire ligament. I use a peppering technique where I spread it around a little bit to make sure I get it all over. Not everybody does that. And there is one exclusion. If you're injecting inside a joint, obviously you're not on bone. You want to just inject intra-articular. Proliferant solution. This is a standard proliferant for, I'll use 4%, 4 cc's of dextrose and 6 cc's of procaine or xylocaine mixed with saline. Really you don't want to use stronger solutions than this until you become very proficient and experienced. Results often curative, significant improvements in function, pain, same outcomes as PRP. We talked about that. Just because it's sugar doesn't make it safe, okay? I've heard a lot of people say, oh, it's natural, it can't hurt you. You're putting a needle in people, you can hurt them, okay? You should start in peripheral joints, knees, ankles, elbows, and progress to more complicated structures where there are tissues close by that you can hurt. Anytime you're putting a needle in someone, you can hurt them, okay? You shouldn't be doing prolotherapy over the spine unless you have resources at your disposal to run a code, because you might put some stuff intravascular or intrathecal, and you could have somebody go out on you right like that. Okay, these are long needles you're using to treat the spine. Unless you're trained, you shouldn't be doing the spine unless you are trained how to take care of a complication. Okay, so train yourself up, get some ACLS training, get some equipment in your office if you're going to do the spine, particularly the neck area or the lower back area. Okay, it's as safe or as dangerous as any procedure doing anything with that needle. The fact that you're putting dextrose in doesn't make it safe, okay? Probably is safer than cortisone because you don't have the complications of cortisone, but it's still an injection. So in summary, prolotherapy is a regenerative injection. It's a concept of understanding musculoskeletal injury and repair. It's a way of thinking about disease and diagnosing the patient. It's a treatment methodology to ensure complete treatment of the patient and the injury. It's a great add-on to PRP. In other words, if you are doing PRP of the knee and your kit that you got from Harvest or someone else, gives you 5 cc's of PRP, what are you going to do with the rest of those ligaments around the knee after you dump the 5 cc's in the joint? You got to have something to get the rest of those ligaments, otherwise you're going to have a treatment failure, okay? That's where you can use prolotherapy. I usually use prolotherapy with all my PRP treatments, okay? And there's some things that, ligaments just respond so well to prolo, and you just don't have enough PRP to go around. So it's a great add-on to other regenerative injection techniques. It's well-researched. It's not experimental. And some more advantages to prolotherapy. When you visit your Aunt Molly, you can treat her arthritis, because all you need is your bag of tricks and a bottle of dextrose. You can treat your spouse, your kids, your relatives, and your friends in your own home. You don't need a collection of machines and expensive equipment to deliver a really powerful treatment for most musculoskeletal conditions. Your intellect, your training, and a bottle of dextrose is all you really need. Think of the power of that. You just don't need anything else to fix people. So that's my story on prolotherapy. I hope I've convinced some of you that it's an important tool, that you need to think about the whole structure, and you need to think like a prolotherapist if you're going to be a successful regenerative medicine therapist. Thank you very much.